Okay, thank you. We've got, as you say, we're mixing and matching here. We're going to have all folks that you've seen before, no new faces this time. We certainly are encouraging the questions, great questions coming this way. The Twitterverse, please, what is that, at Best Hospitals, or not at, what is that thing? Hashtag. God, my technological frontier ended with Twitter, I'm sorry to say, but I'm going to try to learn what that is. Hashtag Best Hospitals, please send the questions, and we're going to have some time for all of you to come forward as well. Okay, the third and final panel, business. It's cropped up in a couple of conversations here, the rankings as marketing tool, as part of a marketing strategy, as part of a business strategy, business model, deals with questions of specialization and in some cases maybe crass commercialization. So all of those are fair game. Let me start with Steve. You are existing in an extremely competitive market. You're a hospital that has done well in the rankings in many respects. What do they mean to you from a business standpoint?
I think this has been spoken about before. It certainly carries great valence at the level of the Board of Trustees, whom I answer to, and so that is of significance. I think it carries valence with donors. I don't think it carries a lot of valence with how the hospital runs day to day. I don't think it carries valence with the business model of the hospital and what we're trying to accomplish. And quite frankly, I don't think it carries a lot of valence in terms of recruitment and retention of faculty. I don't think it's a big driver. I do think it's important in the larger sense of when you're dealing with board members who do represent the community and philanthropists. They sort of want to understand, am I associated with a terrific place? So I do think it carries significant weight there. And you heard, I guess, from the Mayo Clinic that they looked at areas that they weren't getting points in and figured out outside of their normal budgeting process, how do we get points there? And I do think it carries that type of weight when you look at where are we and where do we think we would invest to get better. And I would imagine that that's why everybody is in this room.
Right. So, well, I mean, it's a good question, I think, for everybody. I want to sort of walk down the line. Sharon, what do they mean to you from a business standpoint?
Well, I would echo kind of many of the things Steve said from our board level. It is incredibly important, and I think accentuated by the fact that both the university that we are wholly owned by, University of Chicago, and then the Pritzker School of Medicine, both that enjoy rankings from U.S. News and World Report and have increased on those. It has increased the focus on understanding and wanting to know specifically about what the action plans are to elevate the medical component of the enterprise. So it's incredibly important from a board level, a philanthropic perspective, a reputation perspective. I don't think it influences retention of faculty. We know from our own market studies it really is not shifting business around to the places. And Chicago's been kind of an interesting market where despite its size, and having 5 academic medical centers, it's not one that has, for a long period of time, when you look back over the 20 years, has had U.S. News and World Report rankings. It doesn't mean that there's not absolutely kind of great care. But from a business perspective, I think when we look at where is competition in the Chicago marketplace, it is from growing and emerging large community hospital systems that aspire to develop aspects of their delivery model to overlap with what the academic medical centers have traditionally done. And one of the things that is absolutely kind of fascinating in the Chicago marketplace is the number of these large community hospitals from I will say, a reputation and a brand perspective, and their belief that it will shift business, that are going outside of the market and branding, co-branding their services with U.S. News and World ranked hospitals, and we're just watching that occur. Every 6 months or so, there's another adopter of that. And to the AMCs in Chicago, it's an interesting business change within our marketplace that I think speaks to, this is, to a large extent, is about brand management, it's about reputation management, and positioning in a marketplace.
Do you think that's a healthy development for you or unhealthy?
We have not sorted that out as yet.
Okay. Phil?
Sure. I mean, I was telling, I think it was Mr. Long, just before we walked up here, that in some ways, I think we're almost talking about some of these areas as though they are independent variables. And so there's reputation, there's the survey that determines reputation, and now there's the business. I actually see them as all interrelated and in many ways self-reinforcing. The fact of the matter is that if you are already ranked, you're more likely to have that drive your reputation, and it can drive the responses to these surveys subsequently. And in particular, the way that hospitals like ours and others use the rankings, it makes it not an independent event from the subsequent surveys. And so to come back to reputation and business, for us, for hospitals who have a business model and an economic model where the greatest margins, it's all about, marginal costs and marginal revenues. And if the greater margins are on the high case mix index patients, then reputation is business, and business is reputation. I mean, I think the greater the reputation we have, the more likely that we are to attract other partners, and entice people to send us patients. And the larger the volume that you do, the greater the likelihood that you'll have a much better reputation in that area. So for us, they are interwoven and they do drive our business strategy and where we invest versus not.
When you open the New York Times Magazine and see a big glossy ad which has the U.S. News logo, best hospital spread around and an unnamed hospital underneath it, one of your competitors, how does that affect you? How does that affect your business? Is that bad for business for you?
Well, I personally find it rather inconvenient.
Okay. We've got some people who can help you here. Mary.
Sure. Well, I will certainly echo what my predecessors have said about the board and the foundation board. Our donors certainly view this as a hallmark for them, and they're very proud of it, and they like that. I exist as a 255-bed children's hospital in Memphis, and there's no competition for about 200 miles around us, and the other children's hospitals that surround us are very well ranked and very credible and do wonderful jobs as they should. So we're pleased with that. But I'll offer you a different perspective on business. What has happened at Le Bonheur since our rankings 2 years ago, we have seen our employees, our associates, be incredibly engaged now. They are proud for themselves. They enjoy that sense of that they're doing something extraordinarily different. And so from the perspective of our ability to recruit and retain our staff, from our environmental service workers all the way up to our leadership team, they enjoy it, and they like now being part of multidisciplinary teams that help to drive and look at the quality metrics around U.S. News and Report. I think that has been a paradigm shift for us that I think has been a driver from us participating in the rankings. The other thing that has been interesting has been our business community, which I'm sure, like many communities, is always looking for economic drivers for business. Our Chamber of Commerce uses our rankings in their advertisements. We let them do that. We obviously share it with St. Jude Children's Research Hospital, which is a terrific children's cancer research institute, of course. So organizations that have their headquarters in Memphis, FedEx, use it as part of their marketing recruitment tools for bringing in young executives and talents, because they are parents who have to think about how their kids are going to be cared for and what are the resources in a community. So we've seen our business community really relish it more than we relish it, to be honest with you. So it's been, not that we aren't very proud of it, we are, but they've used it in a business strategy that we haven't. We're using it from the perspective of philanthropy and quality improvement, as I said, which has been the fundamental driver for us.
Okay. Peter, maybe I would just skip over you. What's the point, right?
Well, first
Never
I wanna say
argue
that
a winning hand, as they say in poker. No, I'm sorry.
we try to keep these rankings in a lot of perspective, and I think we don't view the competition as Johns Hopkins, Mayo Clinic, or the other hospitals represented here. We view the competition as cancer, heart disease,
Right.
mental illness, and all the other diseases that affect our patients and their loved ones. So that's job one. That having been said, we respond. I mean, there's no doubt that we and other hospitals respond to these external, visible assessments of our performance, be it the CMS value-based purchasing effort or the Joint Commission surveys or U.S. News, and we try to take steps to get better in a lot of areas, but there's no doubt that when we're being publicly assessed, we do pay probably disproportionate attention to those measures and those improvement efforts. When it comes to the Joint Commission, we have, over the years, looked at what specialties are at risk for losing a point, gaining a point, and made some modest investments to try to prevent or encourage those things from happening. I was amazed at the reaction that we've received since moving from 2 to 1. The most impressive part of it was among our staff. This was just an incredible sort of shot in the arm for them. I mean, they're pretty upbeat as it was, but the people within the organization were just really excited by it. There's no doubt the board was pleased. There's no doubt that it's had some unmeasurable impact on patients and referring physicians. We've seen significant increase in our patient activity over the last year. My sense is that there's been a further inflection point since this survey came out. Our emergency room has never been busier than it in the last few weeks. So despite all the products that are being put in place in Massachusetts to try to prevent people from coming to places like Mass General Hospital. And I also have no doubt that this has had an impact on our donors. There's definitely a buzz at our events over the last few months that is palpable. I guess one other thing I want to say is that this also taught me a lot about Johns Hopkins. I've admired from a couple hundred miles away their clinical and academic prowess, but I also learned a lot about their graciousness. I received a wonderful call from Ron Peterson, the president of the hospital, the day the results were received, and we also received a wonderful gift basket of Baltimore goodies from Johns Hopkins as well. And I brought that to the next Chiefs meeting that we had and said, I'm not personally looking forward to having to send a Boston gift basket to anybody else in the near future. So, but anyway, Hopkins was just incredibly gracious, and it's always been an honor to be mentioned in the same sentence as them and these other institutions. So that was a wonderful lesson as well.
So, you know, it's an interesting point, though, that you would like to think that this encourages a healthy competition that has value. I mean, does it mean, you know, does a doctor work an extra hour or a nurse? Do you think it has that sort of? And then at Hopkins, obviously, they're saying, wait a minute, let's try a little harder here. Is that a realistic way of viewing this as a good outcome?
I'm not sure that people are working any harder, but maybe a little bit smarter. I mean, we are focused maybe more on these patient safety indicators as complicated and maybe inaccurate as some of them are. So we're focused on some of the opportunities for improvement, and I think the U.S. News survey and some of these other external activities definitely help shape, to some degree, our quality and safety priorities.
Yeah, good. Vinny, tell me about your thoughts on this.
Yeah, I would have to echo what Dr. Slavin just said for the Mass General, there is an importance, among faculty and staff at the University of Michigan and our brand and our reputation, and so we take the U.S. News and World Report rankings very seriously, and we take it seriously from the standpoint of trying to improve and continually demonstrate the high quality of care that we deliver, or in areas where we are falling short, have a focus on improving those results. And so we look at these results from the U.S. News and World Report. We look at results from other ranking systems and try and learn from them. In some cases, the learnings are a little thin, and so we ascribe some of the methodological problems as potential weaknesses, and so we try and navigate around those and take what we can of the strengths of any particular rating methodology and learn from that and try and improve our quality of care. The quality of care really is at the bottom of all of this. It is the focus of our attention, and so that really is why we try and understand or learn as much as we can, but it's also why we try and publish information about ourselves, about the quality of care that we do provide in a transparency website. We take information that is available only to us from various registries like the Society of Thoracic Surgeons, Registry for Cardiac Surgery, and post our results. And we do this in a number of different areas and try and make plain how we're performing, even in transplants. Publishing, even though it is public information, I don't expect very many consumers look at the Scientific Registry for Transplant Recipients, and so we publish that information. We try and make it plain as part of our website. So again, the major driver for us is quality of care, and so and that is what feeds our reputation, and so that is why we care. But so I think I can safely say that we're not changing our business strategy as a consequence of these rankings. But I would have to ask, and maybe I'm being a little provocative here, I would have to ask if others are changing their business strategy, because I'm quite astounded that there's so many institutions that have pursued nursing magnet status. We believe that we comply with criteria to achieve nursing magnet status, but we have not gone to the lengths to apply for accreditation and go through the process. And we are penalized as a consequence by U.S. News and World Report, even though we feel, again, that we satisfy the criteria. So I would have to ask, are there institutions that are, teaching to the test by pursuing a nursing magnet status? And that's being provocative, but also asking what I would consider an honest question.
So that's a good question for the audience, and when we move to questions in a few minutes, let's ask, are there people out there? I know we've got a lot of business folks here. Do these rankings affect your business strategy, and is it a healthy thing or an unhealthy thing? Love to hear some of that. I mean, one area that has come up in tangentially is the notion of specialization, and the rankings celebrate specialization in a certain way. Is that a good factor? Is that helping you with helping hospitals, showcase their specialties, and are we sorting the market, helping sort out the marketplace in a good way? Throw that out there to the panel.
I think it gets back to some of what we spoke about earlier, and I think that to Peter's point, you have to put the rankings in perspective and what questions are you asking. So part of the question you're asking is, where would you go if you were really sick? And if you're really sick, you're going to need a specialist, and you have to choose amongst a variety of different places to go to. That being said, most of us are not-for-profit. We exist for the public benefit. We exist to fulfill a societal need, and so we have obligations in primary care, secondary care, helping the poor, helping the indigent, extending ourselves beyond the walls of the hospital. That's not what this survey is asking. And if you morph it into that, then obviously you would choose some other questions to ask. But as I was saying before, the reason it doesn't affect the way that I want to run the hospital on a day-to-day basis is if I were just to affect a business strategy related to the survey, then I think that it would distort what we have to do as a hospital and what communities we have to serve. And I think it would distort it to the point where I think that it would create real issues in terms of were we really serving the public good. And to Peter's other point, I think that there may be a lot that's wrong with American healthcare, but I think the people on this list, 1 to 50, are part of the solution, not part of the problem. And I think the solution has to do not only with cost, but quality and pushing innovation forward and curing disease and reducing the burden of human disease. And that's what we should all be striving for.
Peter, you had a thought?
Just one anecdote. Probably shortly after the survey was developed by U.S. News in the early 90s, I remember being in a management meeting at Mass General, and we were struck by the fact that I think we were ranked number 3 in geriatrics and had absolutely no geriatrics program. So that led us to think maybe we should create one, and we did recruit a great leader, Ken Meinecker, to lead a new program at Mass General. We thought we had created a superb program, and then our rankings proceeded to go down. But we still have, and then U.S. News stopped ranking anybody in geriatrics. But I want to thank them for giving us such a great gift. We have a wonderful program.
Trying to be a catalyst, Chair.
I would make kind of a couple of comments. One is I don't think it's changing our fundamental business strategy, because the clinical services that we really want to excel in are the ones where the basic science, the translational science, and the clinical practice of the faculty kind of come together, and those are going to be a priority, as well as an intense commitment to the south side of Chicago that is a tremendously underserved population, and making significant investments into strategies that could elevate the health status of that particular population. So it's not really influencing how we're thinking about how we organize ourselves around clinical service priorities or resource allocation. Back to what Vanita said, though, the one thing that did come onto our radar screen was this issue of magnet status, because when we went back and analyzed that, it would have changed the ranking of close to 8 of the specialties. And it was proved to be, actually in retrospective analysis, probably the single most powerful lever across as a systemic change in the institution. So we did go and charge our patient care services and chief nurse to go back and achieve that recognition externally, because it will have a significant influence.
Right.
I mean, as a structural element.
Yeah,
And
absolutely.
it actually surprised us to
Yeah, and I think
great
the question
extent.
about magnet has been one, I think, as Vanita raised, there have been numerous applications for magnet accreditation, but that in and of itself is a positive thing to do if the organization chooses to do it. We have, not necessarily because of U.S. News, but because it has its own value and weight for us. I will give you a real life example of something we pursued, though. As I said, we've used the metrics as a roadmap, and so one of them around the area of neurology in children has to do with the dreaded problem of epilepsy in kids. And so they ask in the survey about, are your EEG techs accredited? Have you applied for epilepsy center status? Well, we didn't 4 years ago have that, but we went through the process of doing that. And I'll tell you a real life change that happened. That accreditation alone looks at different quality metrics for us in epilepsy. We had been very grandly patting ourselves on the back and saying we're doing a wonderful job with this 30-day post-discharge. These kids are doing great and they don't have seizures. But the separate accreditation that we pursued actually asks for a year. And so we had a big aha moment that said, duh, you know, we had sort of been fooling ourselves about where we were at, and so it took us a next step, and I would say we are a better organization, a better care provider, because we followed that path to really drive care in a different way, and I'm pleased with that, and that's why I say all the time we use them as almost a free external advisory board, because I get all of this great input from really experts across the country that, we look at separately and we say, yeah, this is one we need to do because it really is going to change the way we take care of kids. And that, for me, ultimately is the goal, taking better care of kids regardless.
Right. Thank you.
Well, you just have to be careful on some of these. I think, I could be wrong, but you'll get the gist of this. I think that in the pediatric survey, one of the criteria, one of the questions is, do you have a Turner's syndrome clinic?
That doesn't count, I have to say. Take it off.
Okay, so now we take care of Turner syndrome kids. I'm sure many people who take care of kids do that. But we were not going to invest $250,000 to establish a clinic for Turner syndrome alone.
Right.
And I think that what I would urge all of you to look at is there are distortions that are created by the survey that would be, I think, wise to eliminate. And whether Magnet is one or Turner syndrome is another, I think you have to be really careful about that.
Right.
Bill,
I agree. I think that whenever one has a distribution that is very tight, and that's what our data show, that when you look at many of the hospitals, they're very tightly clustered in terms of several of the metrics. Then whenever one introduces a dichotomous variable in there, you'll get big swings. And the fact of the matter is that reputational scores, to my mind, are a dichotomous variable. It's not evenly distributed. There are some hospitals that get 60%, 30, 40, and 10, 12, 5, and then it just drops off. So so that sorts out, and I believe that's why that gives you bigger swings. Magnet status is also that, and the weighting that is given to it, and I believe this year there was even more weight assigned to those numbers, also will give you bigger swings. So it should not surprise anyone, therefore, that institutions will respond. The reputational needle is a very, very difficult one to move, even over a 3 or 4 or 5 year span. The nursing magnet status is difficult to achieve, but it is doable and perhaps more easily doable. Yeah, so I think that it is obvious that many places will try to do that. Incidentally, I don't quarrel with the magnet status because I do believe that nursing care is a central part of the outcomes of patient care. So I assume that there's wisdom there, but it does create a big swing. And we looked at our data and found exactly the same thing. If we had magnet, it would have moved several areas, many numbers up.
I want to call for questions, and please, microphone over here. Please be the Twitterverse is chiming in. So, what we sort of did is there any evidence that rankings correlate to any or better patient outcomes? We sort of, Brent, that's your specialization.
Yeah.
Right? They don't. So okay. but there's a lot of other important stuff. So I want to raise the question we've touched on about the broader rankings. About some of the questions here are maybe there's only so much we can do with the structure we're in, but we have there's a bigger universe. There's some other things we need to be looking at. Our business strategy is like a youth soccer team. We want to give a trophy to everybody. So we're going to find a way to come up with a ranking: best gift shop, friendliest hospital, cheapest. Just kidding. So my watchdog is barking at me here. So we announced, Avery today in his blog set down the terms of which we are going to start to undertake an inquiry into a much broader ranking that will look at routine care. So I wanted to, Avery, why don't you just give us a quick summary of what that is, and then get some responses to that, and then some responses from the audience.
I alluded to this very briefly before, the idea of going beyond best hospitals and patients who fall into the difficult to treat category, and looking instead at the reasons that most people need to go to the hospitals for inpatient care. And most of those reasons fall into a relatively small constellation of conditions and procedures. What we are going to begin to look at, what we've already started looking into, and you can get an explanation of this in a post that is running now at www.usnews.com/secondopinion, second opinion, one word, where we post our views, our thinking, our ongoing notion of how best to measure healthcare performance. What I've laid out is a game plan, a very tentative game plan, or at least the goal for a game plan. And that game plan would be to assess the quality of hospital care for some roster of commonly performed procedures and commonly encountered conditions that don't necessarily take into account only the high severity patients, the most difficult procedures, that sort of thing. The idea here is that probably thousands of hospitals in the country, out of the roughly 4,800 that we look at for best hospitals, probably I would guess that 3,500 or 4,000 of them are large enough that they do a good number of the most commonly performed procedures like joint replacements and bypass surgery and valve surgery and spinal fusion and so on. And many of those hospitals perform labor and delivery. We would like to get beyond the Medicare population and look at that too. And of course, joint replacement itself is now not simply a Medicare procedure. Many people younger than 65 have it. So what we want people to be able to do essentially is to find out how their hospital that's of a sufficient size that it does one or more of these procedures, however we define the roster, does at performing the procedure. We're not sure how to do this yet. We're not sure where the data will come from. The states have hospital data largely locked up, either because hospital associations in the state will not release it, or for political reasons, or because of budgetary constraints and other current realities that put the data there but make it difficult to process. We're not sure how it would be risk adjusted. We're not sure how to do, in other words, what it is that we want to do. We may have to start with Medicare data supplemented by some state data. What we need over the coming weeks and months, as you'll see from the last sentence in this second opinion post, is help from outside. We need you to help us figure out how to best do this so that it's credible, so that it has face validity, and so that it provides genuine assistance to somebody who is looking for themselves, for a friend, for a family member, for the best place to have whatever it is that they need. I'm being very vague about have or define. In some cases, it might be volume. We've already started looking into labor and delivery. For example, one of our ranking competitors posts complications, fetal deaths, that sort of thing. To us, that's not necessarily a realistic set of variables that people would automatically consider when thinking about where to have a baby. They would want to look at the percentage of C-sections performed for a first delivery. They might want to see the percentage of episiotomies, might want to see subsequent C-sections. There are other things. We just don't want to claim that we know right now how to measure or put parameters on all of the things that we want to measure. But we want to start this. We want to do it as quickly as we can do it responsibly, and we will need your help. I would urge you again to look at the second opinion posted today and let us start hearing from you.
Great, Savory. Thanks. So from the panel, responses, please. Peter.
Well, first of all, three things. First, I applaud U.S. News for trying to move into this space. So that's very good news. But secondly, well, I have two words of caution. First, I trained in internal medicine, and I still can't remember ever seeing a patient that came into my office with a label on their forehead that said, I'm a straightforward patient or I'm a complicated patient. And so the triage, I think, is one of the most important and sophisticated parts of the whole medical care system. So that's, I guess, one word of caution. The other is, particularly if you're going to focus on procedures, probably the easiest way to look good on procedures is to do them on people who don't really need them or who are have marginal indications for them. And so I hope if you go in that direction that you will try your very best to adjust for that. And that's easier said than done.
Yeah, Vinny?
I also applaud your plan to move into this space as well. I often wonder, as at least have during the course of this morning's session, why, as we're talking about maybe additional metrics and even new horizons for ranking hospitals, for different patient populations, why you or no one has suggested that we take a page out of your playbook from the Children's Hospital rankings in establishing expert panels to help define how this could be done and done well. I think these are excellent points, and I would suggest that that's one way of accomplishing this, and in a way, so that the physician community, the hospital community, can feel some sense of involvement in the process.
Good. Yeah, other thoughts, please, reactions? Real-time news, I guess. It's practically, I applaud Avery's candor, because I would never admit that I didn't know as much as he admitted he doesn't know. But I think it is in the spirit of openness that we really, and I think, Vanita, your point is exactly right. We have, in fact, looked exactly at the Children's Hospital model as something that's worked well, that was able to allow us to embrace the community and do it from the bottom up, which is what we're saying here. So that's good. Other thoughts, but in the meantime, questions? Anybody from the audience wants to respond to Avery or some of the other points we're making? Yes, please.
Hi. First of all, I want to thank you all for hosting this meeting, and thanks specifically Avery and you, Brian, and Dr. Davis. I'm Dalal Haldeman from Johns Hopkins. Should I turn my head? I want to congratulate Dr. Slavin again and tell you that the basket was my idea. I have to also jokingly but seriously tell you that since I joined Hopkins 6 years ago, every year we've had a basket ready. And I thought I was going to send it to my colleagues at the Mayo Clinic. So, on a serious note, even now, if I am in marketing, communication, and market research at Hopkins, I did have in my career a time when I have a PhD in food science and nutrition, and one of my positions was actually an executive director of quality at one of the city hospitals in Cleveland. And even at that time, I thought exactly like you have all been commenting, that if we are doing all those measures to help patients make decisions when they have to make a difficult decision to whether they would travel out of their zone of comfort to seek health care, in my opinion at the time, there were 45 different ways of reporting mortality. There were so many ways that people were reporting quality and outcomes. The one, to me, that was the easiest to look at was the U.S. News and World Report, even at the time when I was in Cleveland. And to me, despite all the discussions and the criticism that you hear, and maybe self-serving comments that myself and maybe and others would offer to change and suggest methodologies that would favor perhaps their own institution. I do like what you said, Dr. Slavin, that really the enemy here is curing the disease. But if we want to look at the US News, you can look at reputation alone. Just look at reputation alone. Hopefully that peers can assess each other a little more than the commoner who are not physicians. And if you want to look at a real outcome for a complicated disease, what's more important than coming out of the hospital alive? So you would look at mortality or survival rates. So my question to the panel is, how do you look at that piece of US News in looking at the survival rate and mortality? I know it's only MedPAR data. And how do you compare this to other mortality indices that other institutions put together or that you look at together yourself?
Okay.
Thank you.
Anybody want to take that?
Well, we look at all our it doesn't take U.S. News for us to look at all of our mortality indices. We look at that in our transplant programs. We look at that across the state cardiac database, and so on and so forth. I think that all of these risk adjustment methodologies are fraught with problems. None of them are perfect. And I think that things need to move in a direction where it becomes a better way of measuring outcomes over a period of time. But I think that I can't imagine anybody on this panel not thinking that they're going to be looking at those indicators regardless of whether it is important to U.S. News and World Report. I think it's important to us as providers to take a cold, hard look at what outcomes we're achieving. I would just caution us that, take for example, looking at routine care. Is congestive heart failure routine? A lot of community hospitals do it. I would submit to you that congestive heart failure at New York Presbyterian or at Mount Sinai or at University of Chicago is not congestive heart failure that you see at community hospitals that surround us. It just isn't. And the risk adjustment methodologies do not accurately reflect that. They just don't. So I just think we need to be careful about what we're describing as routine and how we move in that direction. Because I think that if we put too much faith in the risk adjustment methodologies, I think it would be a real issue from my perspective.
Benita, you have a thought?
Yeah, I would agree with that. I think the risk adjustment methodologies are fraught with problems. Recently, we looked at our gynecology mortality from U.S. News and World Report and observed that it's largely driven by patients with advanced cancer and patients who have been discharged to hospice. And so we wonder what we can learn from that. It suggests that there are methodological changes that could be made to improve the risk-adjusted mortality. In addition, just to note another observation, it appears that in the neurology and neurosurgery specialty that hospitals with a level 1 or level 2 trauma center have worse rates than those without. So I think there's the influence of trauma cases that may need to be taken into consideration as well.
Peter, you?
So mortality seems like a pretty straightforward measure, but as you indicate, it can be pretty complicated, and even mortality can catalyze perverse incentives. If you look at percutaneous coronary interventions in, I believe, both New York and Massachusetts, since there's been public reporting of mortality, the single group where patients benefit the most from angioplasty or stent placement is when they're in cardiogenic shock, and it reduces, these numbers may not exactly be correct, but it reduces the mortality from 40 to 20%, but it's still much higher than an elective angioplasty. I think in part as a result of these publicly reported measures, the number of patients getting treated with angioplasty in cardiogenic shock in both of these states has plummeted because people are afraid that it's going to adversely affect their numbers. And so I would argue that these public reporting systems in both of these states have adversely affected care. And I guess taking it to extreme resulted in people dying who could have been saved.
Phil.
Sure. I'll just.
Could you go back to that just for a minute? What sort of care are people who present with cardiogenic shock.
They may be getting heart surgery, or they may be getting supportive care, but no coronary intervention.
No antithrombolytics.
Oh, maybe medical therapy, but no procedure.
Phil, yeah.
Sure. I'll just add that, you do raise a very good area and point. Mortality is important, but it's only a sensitive differentiator in the areas where there's relatively high mortality. So in conditions where there's very low mortality, once again, the spread is very narrow, and so it doesn't really sort out, the top places from the lower place, from the not so top places. But in those cases, other things might be important. Morbidity might be important, and so you can survive, but can you walk? Can you talk? Can you see? Etc. That makes it just a little more difficult. And then I'll just point out, listening to the exchange between you and Dr. Slavin, I just want to now, while the burdens of moving from number 2 to number 1 on the list are entirely unfamiliar to me, I'd just like to point out that every time I receive a gift basket from the competition, I don't feed it to my chiefs, but rather I re-gift it and send it to another competitor.
Let me say, I didn't feed it to the Chiefs. I ate it myself.
This could go on, and it's very productive, but we know that everybody's got day jobs, and we have some other things that have to happen here. We're going to ask Ken Davis to sum this up, put a finishing touch on it, and then I'll be back to say goodbye. So, Ken.
Well, I want to thank everybody who's come. I want to thank the panelists. I want to thank U.S. News. And knowing that I stand between you and lunch is not a good thing. Nonetheless, I have a few things that I want to say in summary. And I want to begin with what we've just been talking about, which is really the tension between a list for the best hospitals and a list for really the best community hospitals and what is the best routine care. I really want to underline what you heard, Avery, and that is to say congestive heart failure at MGH and congestive heart failure at New York Presbyterian and at Mount Sinai isn't the same as congestive heart failure in lots of other places. It may not be the same because of the socioeconomic variables that we talked about that precede where people come, or it may not be the same because the reason patients are getting care in these hospitals is because they already have a number of comorbidities that are, as we know, inadequately addressed by the variable factors in the MedPAR data. So there is a tension between rating the best hospitals and rating the best routine community hospitals. And the more that we don't differentiate those two, I think the more U.S. News should be concerned that the good reputation they've so far been able to inherit for what they've done could be lost by being overly zealous in what's required to really evaluate routine care. But I want to take Avery back to what Mort Zuckerman told you. Mort Zuckerman started this because he said, when he was on the board of MSK, he said, my friends asked me where I should go, right? He wanted to know where the best hospitals were. And to me, that still raises the question of where are the best places to get the innovation and the care of tomorrow. Now, you said that you didn't think that your evaluation system needed to take account of research. And I think that forgets what really translational research is and what happens in our best centers. And let me give you a number of examples. If you're an 85-year-old with aortic stenosis, you really need to know where the percutaneous aortic valve trial is. And you know that if you can look at the best hospital list. You don't know that if you somehow think that innovation doesn't matter among these hospitals. If you're today a patient with lung cancer or a patient with colon cancer, we now know from genomic screens, from large NIH studies that have just been completed, that a subset of each of those patients are going to respond to Herceptin. Only the best hospitals are going to be able to have the genomic capability to answer for that question, whether they should get Herceptin. I contend that a real important part of innovation is what's going on in the world of IT today. The hospitals that are represented here have spent upwards of, in excess of $100 million, in Mount Sinai's case, $170 million, wiring themselves up. We believe that that produces better care. We believe that's a very important technology that facilitates decision support as well as other decisions that we make around the care of our patients. That doesn't happen easily. And I think we have to take a look at that technology list that you guys evaluate and ask ourselves questions like this. Is robotic surgery and its presence really as important as, say, having a totally wired hospital with the highest IT connectivity? I would argue that robotic surgery has become just a commercial catch-all, that I see it on billboards, that every doctor can do robotic surgery. But what I want to know is that robotic surgery necessary? Is it better than laparoscopic surgery? Is it going to have a better outcome for the patient? Well, the data doesn't support it except in a very small handful of indications. Perhaps in the hands of really great urologists, prostatectomy. In the hands of some ENT, clearly an advantage. But the GYN oncology literature doesn't suggest that robotic surgery has any advantage whatsoever. So as you look through those technologies, ask yourselves, what really makes a leading academic, a best hospital that Mort Zuckerman wants to send his friends to, and what doesn't? And I think some things are missing. And another example of that, clinical trials. People come to the best hospitals to get the medicine of tomorrow. You don't know that unless you have some assessment of their clinical trial portfolio. That's easily obtained by the NIH grants that they have to do clinical trials. It would be better obtained if we had an assessment of what the AHA survey would ask that question, how many patients in your hospital are in clinical trials. But I think a best hospital should have that. And to me, not including those keeps us from making this as great as it could be. So a few last concluding comments. We talked about administrative data. My suggestions remain, we didn't talk about it, that V-codes will help a great deal. It will help adjust some of those mortality statistics so that people can less likely game the system. I think we've talked a lot today about socioeconomic variables. You've talked about that you take a look at them in colleges and universities. I hope you find a creative way to deal with that because it disadvantages a lot of our hospitals that take care of some of the sickest and most impoverished patients. And as the social safety net in America continues to deteriorate, that will continue to disadvantage some of the most important hospitals in America. So with that, what I really want to conclude with is tremendous thanks to the U.S. News people for their ability to listen to this feedback, for their transparency and their candor. It is unusual that a group like this would come together to deal with these kind of questions, and I applaud you for being able to do that. Thank you very, very much. For those of you who are coming to lunch, I should say lunch, for those of you who are participating in our luncheon, it's in the Annenberg 5 conference room.
So just one quick couple of concluding remarks here. I just want to thank our panelists who've been done yeoman work here for a long session, really helped open our eyes. I want to thank Ken and Mount Sinai for being a great partner with helping us put together this discussion, one of many discussions we have about critical issues. It's a series that we intend to continue. To some of the specific points Ken made about the technology and hospital of the future notion, stay tuned, something we're very interested in. You know, there's the revolution in medicine wasn't really the topic here today, but there's so many important, interesting things going on, and we want to be a part of it. We want to find ways to reflect it properly as it evolves. So genomics, technology, et cetera, big ideas out there that are important. Anybody has thoughts on that, please come our way. And thank you all for being a terrific audience.